So without taking much time, let me give the mic to Francois. Yeah, I got it right. Previously you're in the panel, now you are moderating the session, so all the best, and we look forward to an interactive section. Welcome.
Thanks very much. This is what you call sweating the assets, right? It's a pleasure to be here again. Thank you to the organizers for inviting me to moderate this session, which I think is something slightly different for business schools. Some have been interested in the topic of healthcare for many years. Some are growing new interest. And it's really a pleasure to have people who spend their lives interested in innovation in healthcare. And I'll quickly just introduce them, and then we'll talk a little bit about what the opportunities are for healthcare innovation in Africa, and then hear some of the thoughts from these panelists around their own work, interactions of the different industry sectors, academia, government, and what the opportunities might be for business schools to engage in this world. On my far left, Dr. Dube, Samu, we're delighted that she's joined us. She's the head of business development and strategy at Philips Healthcare. For many of you who may have been following the more than century-long business of Philips, they split last year into healthcare and lighting business. So we're delighted that she's here. If you look, I encourage you to look at everyone's bios in the panel, in the booklet. Dr. Dube has an impressive CV, a medical doctor, 15 years of experience in healthcare industry, an MBA from WITS, Masters in Investment Management, as well as a lot of real-life work experience. So, Samu, we look forward to hearing from you. Right next to her, Giovanni Milandri is now currently doing his PhD in health technology at the University of Cape Town. He spent many years looking at health technology. He was the health technology project manager at the Medical Research Council and has some very interesting experiences from helping inventors, doctors, engineers work together with government in developing their technologies. So welcome, Giovanni. And Professor Kit Vaughan, who's now emeritus professor after an illustrious career in biomedical engineering at the University of Cape Town, is also an entrepreneur and has spun out a fantastic invention which he's going to tell us about into a company called CapeRay, which he's the chief executive of. So welcome to all of you. As you know, we have an interesting audience of business schools and stakeholders of business schools in Africa. We want to hear about your work, the experiences you've had in building health innovations in your work. And we're really interested as it evolves, after you kind of paint the picture for us in touch points you may have had with business schools, lessons there might be, gaps you see in the marketplace. As many of you know, healthcare is one of the greatest challenges on the continent, but also a huge opportunity for private sector, but also a huge opportunity for public sector to make accelerated gains. And so this is why, why the question of innovation in healthcare. Yes, we need good management. Yes, we need good financing. But actually, if we have good management, good financing, we're not going to achieve and reach these huge health goals that we've set for ourselves, whether it was the Millennium Development Goals or country strategies. We've got what's known in the medical world as the quadruple burden of disease. We've got huge burden of infectious disease, HIV, TB, growing pandemics, Ebola. We have chronic disease, heart attacks, strokes are now in the developing world outpacing chronic disease deaths in the developed world. We have maternal and child mortality burden, which is still of great concern, and we have violence, trauma, and non-natural death. So this is known, the cluster of these four things at the same time, which has really emerged in the last 2 decades, is known as this quadruple burden of disease, and it's putting public healthcare system under huge strain, but it's also creating opportunities for realizing how new technologies might help us overcome some of these great challenges. So whether it's telemedicine or the use of mobile phones and ICT, or whether it's appropriate technologies that are more affordable and can be widespread, or whether it's service innovation and looking about how clinical services might be delivered differently, there is huge scope and huge demand and huge need for innovation in healthcare. So with that to set the scene, I think we're going to start with Professor Vaughan. Kit, if you'll get us started with CapeRay. Thank you.
Good afternoon, Francois. Thank you for the introduction, and thank you to Corne for inviting me to come and share with you some of our experiences in developing an innovative product which we believe has implications not only for our own continent, for Africa, but wider afield as well. So, over the next 7 minutes, I'm going to answer 8 questions for which this audience might like to have some answers. Question 1, what is the problem? If we consider these 8 women here, 1 out of 8 of them, one of them will be diagnosed with breast cancer during her lifetime. There are about 8 women in the room right now. On average, 1 of them will be diagnosed with breast cancer. But there is some good news. And the good news is, when that cancer is detected early enough, it can be treated successfully. That doesn't mean it can be eradicated, but it can be treated successfully. The normal method by which breast cancer is detected is using mammography or X-rays. And if you consider these 4 images here, these are 4 different breasts of different density. So this is a very fatty breast, and this is a very dense breast. And the bad news is that women who have dense breast tissue, these 2 here are about 40% of the cases, very often the cancer is hidden. It's known as occult. It will not be picked up. That will be what's known as a false negative. When you go to have your standard mammogram, you're given a clear bill of health, but in fact there is a cancer there that is missed. So that's the major problem. Younger women in their 40s tend to have denser breast tissue. Question 2, what is your solution? At CapeRay, we've come up with an innovative method which combines the best of 2 technologies. One of them is low-dose digital X-rays, and the other one is automated breast ultrasound. And here are 2 separate images. This one here is a digital X-ray. You can see the lesion there. This one is an ultrasound, and you can see the lesion there. And what we've discovered is a way in which we can combine the 2 technologies into a single instrument, into a single platform, and take both sets of images simultaneously. Here's the system which we've built. It's known as Akeso. Akeso was the Greek goddess of healing. And what you see here is our acquisition workstation, where the user interface is an iPad. The radiographer puts all the information in there. The images come up on the iPad, and she can then decide whether to accept them or not. There is a gantry. There is a C-arm here, which has both an X-ray, a tube here, and in the platform, which you see from the front here, are 2 detectors. One is an X-ray detector, and another one is an ultrasound probe. And we have wireless foot pedals. The breast is held in position here, and it acquires these images by these 2 sensors sliding underneath the breast from right to left there. Question 3, does your system work? This here is our radiographer, and this is one of our volunteers. We ran a clinical trial of 50 healthy volunteers together with 7 women with confirmed breast cancer a year ago, and we're now about to run a second clinical trial at Kritiske Hospital. Here's one subject that I'm going to show you the data for. FFDM just stands for full field digital mammography, or an X-ray. And LMLO stands for left mediolateral oblique. So if it's the left breast, it's a mediolateral view of that left breast. This lady here has very dense, extremely dense breast tissue. She had no prior history of breast pathology. And the radiologist looking at this X-ray confirmed that there was absolutely no evidence of any lesion. But I point out that this is very dense tissue. What I'll show you now is a video animation. It's the sagittal plane, that's this plane here. And ABUS stands for automated breast ultrasound, and that's of that same view, that left mediolateral oblique view. And the video is just rotating around. And what I'd ask you to do is focus there. What you see comes up a lesion. Fortunately for this lady, and you can tell from the particular features of that dark circle there, that is a benign cyst. It is not a cancer, but it is nevertheless a lesion that needs to be watched carefully. So in her case, there was no cancer. But what our technology allows us to do is shown here, where in the case of the automated breast ultrasound, it's in 3 dimensions, so we can get the sagittal plane, the coronal plane, and the horizontal plane. And you can see the circle there, and I'm not too sure if the people at the back can see it, but they are crosshairs which locate that lesion there. And these are the same plane here for the X-ray, and there's absolutely nothing that can be seen in the X-ray. So a lesion picked up in ultrasound is not picked up in X-ray, and our system was able to show that. So the system works. However, this ultrasound can be improved, and that's what we're doing with this next clinical trial. Question 4, what are the advantages? There is a significant improvement in diagnostic success, and that's good news for both the patient as well as the doctor. There is reduced breast compression, and that's good news for women as well. There is greater patient throughput. We can see one woman every 10 minutes, whereas with 2 separate systems, a separate X-ray system and a separate ultrasound system, it would take approximately 30 minutes. So we can save 20 minutes in time in screening these women. There is a lower radiation dose because of the X-ray technology that we're using, another plus, and a reduced capital outlay. You only have to purchase a single machine rather than 2 separate machines. So we believe there are significant advantages with our technology. So who are you? Question number 5. We have a major investor in the Industrial Development Corporation. We are a spin-out from the University of Cape Town. We have 2 founders, myself and Professor Tanya Douglas. We have some original staff, and we currently have other staff, and they have a share trust, and these are the particular shares that are owned in the company by those various groups. And we're now poised to commercialize a novel product that addresses one of the major unsolved challenges of diagnosing breast cancer, and those are the ones with dense breast tissue. So we're very excited about the technology. So how big is this opportunity that we're going after? This is the global breast imaging market, the revenue in billions of dollars, and it's been segmented into 3 imaging modalities: ultrasound in green, magnetic resonance imaging in red, and X-rays in blue. We, of course, will only be going after the ultrasound and the X-rays, that is after the green and the blue part. But you can see in 2012 it was worth about $3 billion US, and it's expected to almost double by the year 2018. So a significant opportunity. Our intention is to get to market within the next year, and our target is about 3% of this market here. That is about $200 million per annum. Question 7, what about the competition? There are 3 companies, global companies, that have 90% of the market share in the first area, which is full field digital mammography, or FFDM. And those 3 are General Electric, Hologic, an American-based company, but with a global footprint, and Siemens. Siemens and General Electric have automated breast ultrasound systems, or ABUS systems. Here's one of them shown here, that have been certified both in Europe and in the United States. But no company, not yet anyway, has a single platform that incorporates both these technologies, both full-field digital mammography and automated breast ultrasound, and that's our system there. So the final question 8, what are your next steps? Well, first, we're going to complete another clinical trial. We're currently talking to a number of major potential investors who've encouraged us to run one more clinical trial to demonstrate the improved performance of our system, and that's what we're doing next month at Groote Hospital in Cape Town. We're working to secure a joint venture with an industry leader, and some of the companies that we're talking to are those that I showed on the previous slide, as well as others. We recognize that we cannot get a major product like this to market without having a major partner, and so that's something we're working hard on securing. We want to complete the commercialization, get this product to market, and continue to expand our intellectual property portfolio. And we want to build on the accomplishments of our management team, and these are the 4 directors of our business, as well as the engineering teams who are driving this. So I leave you with my details, and I thank you very much indeed for your attention.
Okay, good afternoon, ladies and gentlemen. As I've been introduced before, I work with Philips Healthcare. I don't know whether you know Philips. People remember the iron. I'm sure all of you must have a Philips iron somewhere, and bulbs and things like that. But our biggest business is actually healthcare. And I'm in business development there and in strategy for the group for Southern Africa. I've got a few talking points here, but I want to ask all of you a question. What is one thing that a rich man is willing to buy? Is there a problem? Oh, okay. Okay. What is that one thing that a rich man wants to really have and buy? Yes, sir. To live forever, somehow. And what is that one thing that a poor man actually would sell his cattle, goats, and cats, if they've got any, and maybe they can sell their wives as well to try and buy? What is that one thing? It's healthcare. And unfortunately, this particular industry, the traditional market mechanisms that we all know about of demand and supply, don't necessarily work perfectly. And that's the challenge, because we think when we're talking about innovation that I'm going to have a Walla product and traditional market mechanisms are going to somehow meet in the marketplace and everything is going to be fine. But that's not what our experience is. So I'm going to give you a perspective that we have also from an industry point of view, also how then this would interface with what business schools need to do to develop this industry to become what I wish it should become. So first, if you are all aware, when you're talking about healthcare, especially in South Africa today, I was actually reading about this inquiry on private healthcare that, you know, we are driving prices up. We are driving prices up through our technology. Now we are bringing in CapeRay. Again, it's going to be so expensive. So what do we do to try and bridge the gap between we don't have enough resources to make healthcare the healthcare that we aspire to be? And even though we are pushing from civil society and all these other agencies who say every country should budget at least 15% of their GDP should actually be a contribution towards health. And actually, even European countries are not contributing 15%. So is that realistic, number one? Is that sustainable, number two? And what are we going to do about it? And there lies the answer. The answer that we have, ladies and gentlemen, is the answer that says innovation. But we know that the challenge is not enough. And right now, over the past decade, we have seen many innovative ways of doing things. However you define innovation, because from Philips, we define it as an evolution and adaptation of the marketplace where we are so that you can improve health outcomes of a particular population. But we know that what we've been doing so far is not enough. It hasn't been enough to actually change the dynamics of healthcare, particularly when we look that we are doing a countdown to Millennium Development Goals, whereby in healthcare we have failed dismally as a continent, with a few countries, both from low resource, medium resource, who have actually met some of the healthcare MDGs. So, ladies and gentlemen, I believe in this room we've got enough brains to actually solve this enigma, to actually solve the challenge that is before us. Within Philips, what have we done as a company? We have a strategy that, and I'm sure all multinational corporations have got that strategy, where we deploy, we try to redefine what is value. And in any innovative platform, you try to move away, take a step back from the problem, re-look at the problem, look at the solution, step back again, and do this iterative solution, problem journey, other than actually a trajectory that says, I'll start from idea, and then eventually I'm going to, I don't know, Kit, when he started actually with the idea until it actually hits the market, it's quite some number of years. And most of the innovations that we talk about when talking about innovations, they take time. But what we have found is that within Philips, when you are placed in a particular market, you need to have that iteration within the market and on an ongoing basis for you to actually achieve what you need to achieve. So we launched what we call value segment. So value defined as in terms of cost, what you put, and what you get as in terms of outcome. That's how we define value. It's as simple as all that. So in terms of value, if I'm talking about an ultrasound machine, what is it that I want from an ultrasound? I want to visualize a certain image. Can I visualize it cheaper and get the same outcomes? If I can do that cheaper, then I'm adding value. But we actually launched value as in lower costs in trying to deliver healthcare. So our value segment portfolio, and you'd attest, we've got some fetal Doppler, which you can actually wind, and adaptation to the market means you don't necessarily need to plug it into a grid. You know, our ESCOM is giving us problems. Okay, so can you deliver outside, even ESCOM? We don't know whether is it stage 1, stage 2, or whatever, you know, when your lights are off. So can you have technologies that are relevant to this market? I'll give you a few examples that we have actually launched for Africa, like the fetal Doppler. We also have what we call a VSIC ultrasound, which midwives can actually carry now away from a facility, go out there and actually do scanning of pregnant women so that you can detect some of the problems in terms of access you are disrupting. Now, I've got a few, and you can go to our website, we can talk about those technologies. The interesting thing that has emerged, I'm sure most of you read Clayton Christensen's book around innovations in healthcare, which is the Innovator's Dilemma and the Innovator's Prescription. We talk about disruptive innovations. So disruptive innovations say, understand the status quo, and when you understand it, can you actually do away with what is even there and try to do things completely differently? And this is the innovation that actually catches my eye as well, because in healthcare there is so much more that we can do to disrupt the status quo. And so what we have done is that we have got an Africa Innovation Hub that is based in Kenya, where we are actually incubating, because remember, in a company like ours, and I'm sure for most of you, it's the bottom line. So it's the bottom line, it's the first quarter, it's the next quarter, we need to do that. But within Philips, we're trying to take this longer term view, where we are saying, let's incubate, let's put something in the womb, let's protect it from the pressure of the target so that we can innovate. And in there, we actually have got a healthcare innovation where we have built a center in Kenya, which is a community life center. The innovation with this says, once we are going to put technology, because if you look at healthcare outcomes, for most countries, we have improved quite significantly over the past few decades, but we have plateaued somewhat. So if you have plateaued, you need catalytic innovations that includes technology, that includes new ways of doing things, so that you can actually reduce mortality or improve health outcomes. For most of us have plateaued. And in Kenya here, we've introduced technology in this center. It's in Kiambu County, in a remote area in Kenya, in Langata. And in there, we are actually innovating a lot on how you can improve workflow, improve patient throughput, actually improve health outcomes through minimum that you can have. Not only is it about health, because healthcare is not just about a stethoscope and a doctor, and I've learned that. Healthcare is also about the community around, whereby right now your multilateral agencies are pushing an agenda that they say community system strengthening. Community system strengthening, and again, if you recall from Ebola, we needed the community to work together with healthcare so that we could actually tackle that problem. So in our CLC, I call it CLC, is Community Life Center, we also have community engagement, where through energy systems, because you are putting light, you are putting batteries, you are putting solar systems, you are even putting you get energy-enabled spaza shops, if I use that word. Spaza, like little stores where you start building enterprises around the community. From the revenue, a certain percentage actually goes to maintain the healthcare facility. And now you're starting to get community engagement in this particular center, and that's what I call innovation. So our journey as a company around innovation is mainly an evolution and adaptation of where we are, rather than to certainly say it's a revolution for us, a new way of doing things. And this is actually what I like. Now, ladies and gentlemen, as I conclude, I want to leave you with a challenge. When I was reading about Baltimore, you all know what happened in Baltimore recently. Why Baltimore burned? There are two words that come. It's about access and equity. So when you're talking about equity and people see that things are unequal, healthcare is one of those areas where you can easily and clearly measure equity, that equity is a problem. So where inequities exist, people are going to revolt. Now, an interesting thing about Baltimore is that Johns Hopkins Hospital, one of the best hospitals in the world, is actually situated there. And yet, citizens around there may not even have the capability or capacity to access those particular facilities. And why Baltimore, I don't know whether you know why, all this, the violence that was occurring there, you find there are two worlds apart within Johns Hopkins. And we cannot divorce healthcare innovation with what is happening in the communities where this healthcare is actually built. We are seeing this daily in South Africa. And last week we were talking to the World Bank President Ban Ki-moon, who actually said, we all know that if we go by the traditional market mechanisms, we are not going to win in healthcare. So what do we need? We need to focus not only the bottom of the pyramid, but the midst of the pyramid, where value is likely to be derived. We will have the high technology there in the apex of the pyramid, but what is in the midst here is primary healthcare. We've got health posts, but we've got primary healthcare. How do we strengthen that? And this is why we've rolled out a various portfolio within our company to actually focus on primary healthcare in Africa, because that's the way that we believe we are going to build resilience in healthcare system. So ladies and gentlemen, for me, my trajectory, my own journey has been filled with those experiences that where I questioned as a young medical doctor working in a kwashiorkor ward. I'm sure you all know kwashiorkor, which is malnutrition. Then I asked myself, why should a child die of kwashiorkor when there's so much food in the world? Then I moved into policy when I was working with your World Health Organizations to try and change policy. We need some redistributive policies in the world. Then I saw that actually you may not talk much of the language when you do not have money. So that's why I ended up saying a company that actually has the resources to back these innovations up so that we can roll them at scale would be something that is sustainable. And because I believe charity is not scalable. Because in Africa, we rely so much on donors, we rely so much on donations. That is not scalable. So we believe that we can push so much more if industry, academia, government, public sector, the multilateral agencies all work together to bring these innovations to scale. Thank you.
Thanks very much.
I'm by background actually a mechanical engineer on automotive sector, and I came into healthcare a bit by the back door, never realizing how complex and interesting it was, but starting to discover. Earlier we had the discussion about social enterprise, social ventures, and I'm starting to realize how social healthcare is, and it's a culture, and it's very much about people. And so if you come in as an engineer, you have to really understand it's not about the technology, it's very much about who you're delivering it to and what are their needs. So I worked for the Medical Research Council here in South Africa and part of the Innovation Center, working with different universities and all trying to get technology out of the university into development and basically to the clinics. A lot more challenging than I expected, but that's actually been scaled up from a 4 million rand program now to over 100 million rand with new investors, and the program is called SHIP, Strategic Health Innovation Partnerships. So I'm just going to give you a bit of background about some of my thoughts about from that experience and just a few projects. I'm sure many more things will come up in the questions. So just go forward on the slides. Just thinking about business schools and the way that business learning is imparted. I just thought of the different, where's my pointer? We talked a bit about case studies, and I've mostly been involved in the design thinking type of world. Products is often that's an appropriate style of learning. And we've got other methods of learning in a business setting. But I think the main thing with healthcare is that we just have so many stakeholders. I think it's unique in that sense that we have the patient, the doctor, the hospital, the regulator, the insurance company, and all of them want their voice to be heard. And so that's why innovation in healthcare is very much more difficult. Just the outline of a design thinking process. From an engineering background, we'd call this an extended systems engineering process. And probably many of you have seen this. Engineers usually work from that define, that's what we would call a spec, all the way towards testing and prototyping. That's the world we're very much interested in. But when we use a word like empathy, then engineers get a bit nervous. But that's what doctors are very good at caring, basically, at understanding what does this person need. And then obviously that interface between the doctor and the engineer is so important because that's many times where things fall down. So just this other way of looking at it, we've got business, viability, that this thing must be sustainable, must generally pay for itself, or at least be financially viable. We've got technology, which is the engineers, can the thing be built and deployed? And then the people, which is, I would say, in this sense, is more the medical community that is contact with the customer. And the different types of innovation. But the main thing is that the different groups must work together, something which I found harder than I thought. This was an article that says basically about how engineers and doctors can work together, but I think business people and doctors, the challenges are very similar. Some quotes from that article. In most companies, it's not common practice for engineers to go to the hospital and hang out with clinicians. If you go to a hospital, there's generally very few engineers. Unless the engineer is willing to incorporate knowledge of medicine in his or her brain, that person is not going to be a good innovator. And I think that's the same for a business person. Unless you're willing to really climb in, that's not going to, you're not going to have a good product. Fresh eyes and experienced collaborators, various backgrounds, open communication, ensure that the well-trodden path is challenged. And that's what we're just hearing about, some of the challenge. And just about engineers not knowing what they don't know. They may think they have a good idea, but further down the line, the regulator, other clinical problems, lots of things can pop up to scupper the project. We saw many projects like that with the MRC. Just some learnings, I guess, in an African setting. Start with our strengths. The mentality is great. Like we really found a good energy, a lot of people wanting to innovate, a lot of willingness to try something and to stick at it for a long time. I think that's a good quality and very human-centered. We've got very unique demographics and culture, so a lot of countries, international companies are interested in South African unique disease burden, which I've talked about, and our culture, and then very highly cost-conscious. So we have to deal with very tight cost constraints, which other people have to deal with, but perhaps we have unique ways of innovating in that. Challenges, obviously, we have a lot of mentality that also says the international companies are here, therefore we must wait for them to innovate. It's a very strong, powerful, sometimes lobby group also in this country, and so then the worlds are split apart of local innovation, which is very small, and the international players where the innovation is happening in the US or somewhere else. So it's a challenge. I had to look after 13 different projects around the country, different universities, just a sampling of them here. As I said, that was very interesting. This was just a mobile clinics project. We used a design thinking approach with an international team, some local engineers and some international ones, to spend time with nurses and to look at what would suit them. Basically, to redesign the mobile clinic experience from the ground up. What are the needs? I mean, even something as simple as changing the height of the desk, because most nurses are shorter than the designers who designed it for themselves. So a lot of little things. So this has been built now in the Western Cape Department of Health. As a prototype, it's being trialed in different areas around the Western Cape, and hopefully that spreads to the national level as well. There's a primary care guidelines, which has been rolled out around the country as a book form, and we were digitizing that, basically to get evidence-based practice into primary care, but on a digital platform. I'll just move through these. This is just an example of what is possible with a connected device, sort of a USB-based cuff. This project has been shelved at the moment, but I think devices like this, in spirometry and other similar devices, I think are very, very useful. The nice thing is that the actual cost of the device, which is being developed, which is over here, this is off the shelf, can be very low cost and can potentially be using the battery from the phone. So there's many ways in which there's a crossover between hardware and software. And then just an orthopedic device. I hope you're not too squeamish. This is for a cleft palate. A surgeon, instead of basically closing, the cleft palate is when there's a hole in the roof of the mouth. And instead of just covering that hole, the surgeon invented a way of actually pulling the bone and closing the hole naturally. So that's been trialed on a number of patients, and they're looking for investors for that. Just two current projects that I'm involved with. I'm busy with my PhD, so there's not that much time for this, but this is just a startup in Nigeria that's got me on there as a technical advisor, but basically about leasing of high-cost capital equipment to hospitals that often don't have access. And so it'll be a leasing model and a servicing and maintenance model, which is in desperate need in Nigeria, where most things are happening cash-based, and it's very hard to get financing. So if you're interested in that sort of thing, then speak to me. And then my PhD is actually just on this rehabilitation cycle, which was developed at the University of Cape Town. They're in manufacturing, and they're basically looking to expand that. So there's a fundraising stage. And yeah, so I'm doing the research on that. Thank you very much.
I think importantly to recognize that Alain Teff from Cameroon was unable to be here with us. He was supposed to be on this panel. He is a young, I think he's 19, Corné, is that right? He was the youngest participant at the World Economic Forum in Davos this year. He's from Cameroon. His flight was cancelled, unfortunately, but he was going to tell us about something called Gifted Mom. So just in honor of him, if you still have your booklet, turn to page 34. And you can just read about him. You may not have met him while he was here, but I think it would have given us a flavor of what young people in Africa are doing with mobile phones. Essentially, it's around using mobile phones to improve maternal and infant health in Cameroon. I think they've started with information SMS services around to women in pregnancy, giving them updates around where they should be, and then once the children are born, kind of what stage the child's development should be in. So it's about creating technologies that can help to overcome some of the lack of access of healthcare in Cameroon. So I'm sorry he's not here, because that would have been really inspiring. Like we heard in our previous panel, the real stories came from the people doing it. In one of my hats, I'd been doing this, that actually Samu referred to, with some colleagues, had been working on these low-cost medical devices. I think the thing that Moses, I don't know if Moses is still here, he was talking about, there you are, Moses, about the women using the horn. Right, it's called a Pinard stethoscope. It's been around for like 100 and something years. And as a young medical student, you will remember this as well. You're supposed to listen to a woman's abdomen and try and count the heart rate of a baby going at about 140 a minute. So I did what every other person does with one of these things, is lie. Because you have no way of, there are good studies to show that in a controlled environment, when it's quiet outside, you can perhaps, actually count what that heart rate is. In a labor ward where people are screaming and someone's moving and is in contraction pain, it's very near impossible. So there's a very clear need for actually counting the heart rate of a baby very accurately, because it's the single most important decision-making tool of a woman in pregnancy and in labor. And Moses' young colleague did something to try and amplify that, and ultrasound has been around for some time. This was a simple adaptation using existing technology, putting it together in a wind-up format, so it wasn't dependent on electricity, didn't need ultrasound gel, can be used with water, and it was taking existing technologies and putting it together affordably, and something that didn't necessarily need maintenance and robust. But starting a new healthcare business from scratch is a heavy business. So we were looking at a 10-year timeline to build a medical equipment company, and one of our routes to market was partner. Here it is in use. That's at Retreat Clinic. And here it is with the Margaret Chan. director of WHO, and Ban Ki-moon, General Secretary of UN, having his heart rate tested, even though it's for babies. Ultimately, at the Africa Innovation Hub in Nairobi, this was launched in partnership with Philips last year to really be able to take something we'd been doing at a small scale and take it to market. And it was because, I think, of a commitment of a company like Philips to say they want a certain amount of their devices to be local, to be appropriate, to coming from the context, to know what's actually needed. So that's one of my hats as on the more kind of entrepreneurial side. I wanted to take one moment to just talk a bit more about this topic, because I think it is important. This hospital in Cape Town is where the first heart transplant in the world was done. Right. So cardiac surgery has been around for more than 100 years in general. The heart transplant was 1967, I think. 67.
December 67.
December 67. I wasn't alive yet. But cardiac surgery, as it stands, has been around for more than 100 years. The reality is today that 10% of the world can access cardiac surgery. So actually developing many more, huge advances in science is not going to save that many more lives. We need an Ebola vaccine. We definitely need more products. We definitely need more vaccines. But the reality is there's a big gap in getting those products and getting those services to people. So this is, do you guys know World Mapper? Have you seen these maps before? So the size of the country is dependent on the data point being used. So here it's weighted. So this is where infant mortality exists in the world. So for the biggest country like India has the greatest burden of infant mortality, and obviously the smaller countries like the US, much smaller. And you can see that the burden of disease is South Asia and certainly West Africa, that's Nigeria, and Southern Africa and East Africa. So that's where the burden of disease is. Do you want to see where the doctors and nurses are? Right? It's the complete opposite, right, of that picture. Supply and demand, free market theory, anyone? No. So the reality is, as someone was saying, that the economics of healthcare is a different story, right? The investment we need in infrastructure is obviously significant, right? We need managers to run these hospitals. We need new medical schools. We need to be thinking about how we grow the service delivery. But even if we did all of that today, it would take us decades to start addressing that challenge, right? So we clearly need innovation as well. Not going to go into the costs of this, but really the one point I wanted to make was really around we need innovation in healthcare delivery. And this is not only about products, but it is also about processes and services. It is also about these roles. So talking about innovations, there's something called task shifting or task sharing, where doctors don't necessarily and nurses don't necessarily be doing all the tasks. So there are process innovations and service innovations and innovations in the roles that actually people have, the way we've set up these professions that are important. And clearly in the financing and in the policy as well. So our work has started to look at some of this at the University of Cape Town, GSB, and the only thing I wanted to really show you was we'd set up a public sector innovation program to actually identify the challenges that lie within public sector. And surprise, surprise, after 73 interviews, there actually were challenges that were reflective of the public sector as a whole, whether it was a primary care setting, waiting times, or a tertiary care when it was really about how patients get to and from the different centers of specialization. And ultimately, we've started to provide a fund for them and created a space that people can really come together, whether it's an engineer, whether it's an entrepreneur, whether it's an IT specialist, or whether it's a company, to come into the public healthcare system to actually do what Giovanni was talking about, is actually embed themselves in quite a complex world, to start working in partnership with healthcare workers, with the public sector, to develop innovations. That's really all I'm going to talk about for now. And then I'm going to open this up to the room for questions, but I'm going to come back to all of these panelists for their experiences with business schools. But let's start with the first round of questions.
Yes, and I find this very interesting just because of actually another project that I've been in touch with that is working not just on getting healthcare technology, but healthcare technology management and management training for people who are dealing with healthcare technology in Tanzania, actually. And I wanted to bring that in. You've talked a lot about innovation and a little bit about the business models of new products, but what about the next step then, and developing the skills to manage those technologies, to train people, and also make sure that, you know, in the supply chain, you know, I like seeing there was no batteries in the wind-up, but there are a lot of different components that go into making these things practical in the field. And what does training have, what component does that have in your planning around all of these things?
It's even worse. We also ask always the same questions. When AABS a few years ago tried to get a healthcare leadership management project started, along with an agribusiness one, it failed. There was not enough interest of business schools. There was not enough interest in the continent, I would say. Secondly, I hate to say, but in our home university, the general acceptance is that these kind of things should be hosted by medical faculties, of which, of course, business school deans disagree. And there are many business schools in the world, particularly outside Africa, who do have strong health management leadership groups. Thirdly, or my third point or question, is it around what is the need? Is there a need for technology innovation? Is there a need, and what's the rank order, of course, is there a need for management, as Paige suggests? Or is there a need, as I think you suggest, for doing more with less, which for me is business model innovation? So if you could comment on those 3 points, I would appreciate that.
Yeah, sure. I can start. I think so your questions are actually similar because they touch on the people aspect of all this. And the interesting thing about healthcare, from my own point of view, is that you're largely dealing with doctors as well. And often they are left behind whereas we innovate, if we don't include them, and I think you mentioned it as well, that if there is no interface between the end user and the particular technology, it may not take off quite well. And so the training that we do, for example, if we install or if we do new technology, within Philips, the package has to come with training, and then maybe supervision, quality check, quality control, and that technology, we want to see the outcomes at the end of the day. I mean, that's how actually the whole selling process and the whole product introduction process actually takes place. But I think the key here is the people part during technology. And for me, what I've found is that unless if you take doctors along with you, because they're quite a powerful group, they're quite powerful, and if you don't bring them along, you are actually, the uptake of your technology may not be that great. And so then you've started to innovate, to say, actually, we need to, how do we address the people part? We need a program, maybe a healthcare leadership program, healthcare management program. The need is there, because you have found, actually, I worked with a hospital in Zimbabwe, which was ISO certified. Hospital, public hospital, sure. ISO certified. And you compare another hospital like 5 kilometers away, it's in complete, I mean, it's in shambles in the same vicinity. What makes that difference is the person who manages this particular facility, who says, I can do things better, who takes ownership, who is patriotic to the particular facility. So your training would then bring these qualities within a facility, within the healthcare arena. And so the need is there. And perhaps you could use the same way we introduce products in terms of innovation and uptake for that program to actually take off in Africa. And I read in the Africa Health magazine that the first book on Africa health leadership written by an African was released this year. The first book, like after all these years, we're talking about Africa's healthcare, the first book was now written, and then we celebrate, we're going to launch it. Meaning we have not tapped into the people who are going to be affected by this. So there is more work to be done to match this need and the solution that we have actually come across. And it's the people aspect. So we need some advocacy. I think we need some diplomatic engagements, but more importantly, we need venue shift in how innovation and healthcare is going to transform. Venue shifting as in, if this is the language that they speak, let's speak that language. If we are business schools in particular, because the war, you will never win it between the medical school and the business school.
Yeah.
I think that's why some of us said we will join in and we get into the business school, because it's a war that says, no, I know what I need, I know what I want. Then you put a surgeon in charge of the hospital. The next thing, you've got all the surgical equipment bought into the hospital. It's not going to improve our outcome. So I think it's venue shifting, and we need to be diplomatic on how we engage these particular stakeholders.
Sure. Yeah, I guess just about the health technology management. I think for a business school point of view, in a sense, the return on investment is almost it's quicker, and especially with the growth of health IT, which is quite a bit behind many other types of IT or ICT, which is growing rapidly now. It's maybe a good first place to start, rather than starting in the medical devices, which is much longer timelines, and the turnarounds are quite, so they're quite different worlds. But the management side of it, I mean, we often think of a hospital as a whole, an enterprise, and it's supply chain, it's organizational management, it's specialities, it's all of that happening in often one building. And so that, I think it's very needed. I don't have direct experience of those things, but just thinking about the innovation side of things, I guess the deployment and the human side of it, we saw this most strongly in the big energy around mHealth, mobile health, and digital health. And I think that's where the digital divide just cuts straight through down the middle, because you take your touch screen, even with an app, no mouse, no nothing, to your nurse, and you give it to them, and you know, 2 days later they're frustrated with it. They don't want to use it anymore. And everybody has said this is a wonderful product, but they are sick of it. They don't want to see it again, or they feel very nervous using it. They feel like they're being forced to use it. And a related thing is that our government put a moratorium on new mHealth projects, because there was actually too many that were coming, and none of them were working together. So there was no interoperability. So this NGO had this maternal health monitoring, this one had this one had this, pediatric monitoring, all sorts of things, but none of the systems were interoperable, and the government would spend all of their time trying to figure out whether these people are working ethically, safely, they're actually dealing with patients. So they stopped access for about a year because of that. So the hype it's very challenging. Maybe just another side of it.
Yeah, just a comment or an answer to Paige. It turns out within the Faculty of Health Sciences, apologies, Walter, at the University of Cape Town, for over 10 years now, within the biomedical engineering program, there has been one that's focused specifically on healthcare technology management. And it's brought in people from a variety of backgrounds, not only engineers, but doctors and others involved in running hospitals and clinics, and it's brought them in from all over the continent. So the real success there has been spreading the word. There has been some interaction, to be honest, with the Graduate School of Business, but it has been led by one person, Malatin Paluta, who's been extraordinarily successful in marketing it beyond the borders of South Africa, and that's been very good. And at the same time that he's done that, he's also got a very nice collaboration going with Northwestern University from Evanston, or from Chicago, where they send about 30 of their undergraduates every year, and they come and spend 2 or 3 months in Cape Town. And they're taken out into the clinics and into the hospitals to see real problems. And then they work in small groups to solve some of those. And they've done some marvelous work there as well. So I think there are some very nice success stories that we can look back on and say there are some really good models that we can build on, so that we don't have the kind of situation which you've just described, Samu, where you get sophisticated equipment bought on behalf of a hospital, and it gets there and is not used and gathers dust, which is an absolute tragedy.
So I have one question as well. So MBAs have typically been attractive to engineers and doctors for many years in all business schools around the world, right? And I know there's an increasing interest in healthcare in general in business schools. I've seen, Strathmore's developed. I know Regent Business School had and there's some business schools in the world that specialize whole divisions, like Wharton as a whole, like 30 faculty members just in healthcare. Some of your experience, did it offer you what you needed as a doctor coming into an MBA? What were the reasons you did it? What do you think could be offered more?
Yeah.
What else?
Yeah, I guess the question...
Where are the gaps, I guess?
Yeah, and maybe the question it's broader than that, obviously, because it's also about entrepreneurship, and yet most of our business schools, at least where I went to, the focus has been on the corporation and how you are going to be a good person within that particular corporation. And at times, for me as a doctor in a business school class, I felt like a fly in the wall at times, because again, you mentioned the issue of empathy starting from there, and then somebody saying, well, we have to push your product. Like, for example, I struggle when I say, push your product, and then this is how you're going to make your sales. I'm like, it's not going to work, because, again, medicine is kind of, you have to have that benevolent heart, and then you have to drive something. Again, so there is that tussle that you find in medical school around healthcare. But again, I think we have to be cautious about this evolution around healthcare and business schools, because in the US in particular, there is a huge problem around healthcare in the US. You have Obamacare, Medicaid, and all these issues that they said, business schools may sort some of this out. And that's why there was these many programs within business schools. We've got a different challenge around the kind of innovation that we need for our own problems. And so we have to be careful around how we actually evolve healthcare and marry this healthcare and business schools. And actually like what UCT is doing, because you also started from a benevolent heart to say, this is a social issue. Then you discover actually there is more. Business can actually do more in terms of bringing these products to scale, which for me is what is missing in some of this. How do you bring them into scale, knowing fully well that healthcare may never change from being this benevolence sector, industry sector. When I'm selling MRIs, I'm hoping that we can diagnose breast cancer somewhere, or we can make this diagnosis. That's the ultimate goal, isn't it? So how do you mix and match that? And so for me, that's what we haven't found a formula in that. But I must say I did enjoy business school. It gave me a newer perspective of how healthcare could run more efficiently and how we could get value from everything that we're doing within the healthcare sector. So I think there is that synergy, and it could be enhanced more, but in a better way.
Good. Well, let's hear from you. Any more thoughts, questions, comments?
No, I just want to give information. The app is called WinSenga, WINSENGA. WIN for win, SENGA. I've just Googled it again here.
Okay, great.
And I think it's working. the guy won $40,000 from Microsoft. And the win means a competition. I think he trotted to and fro quite a number of times. And I believe his app was tested for whatever. But I know it works under, I think, quite conditions. You are talking about a birth attendant in a village, a traditional birth attendant in a village, not in a hospital or a ward. I think it will answer those questions.
I hope we can recruit him back from China one day.
Well, I hope he's coming back. He's been here for 6 months.
Okay.
So I hope he'll come home.
Listening to the discussion about the deployment of health technology, Madam spoke well and talked about how doctors have to be carried along. But if you were in rural Africa, you will see that hardly do doctors get there. A lot of the people who deliver health care, primary health care nurses, some traditional birth attendants, and all of that. And so when we're looking at the deployment of health technology, I'm sure that factoring this into all of the equation would also be useful. the issue of getting frustrated with systems, it's not just for people who have not been to school at all. Even for many of us, we hardly use 10% of the capacities of our mobile technologies. And so when you are looking beyond medical doctors like Madam and many others who would be engaging in very sophisticated medical facilities, you also want to look beyond that and go into the villages, look at what the rural women who support healthcare, those people who have not been trained but are passionate about healthcare, those NGO staff who just for the passion of delivering healthcare are out there in the villages. If we do that, I'm sure that it will help us a lot in being able to respond to some of the health challenges that we face in Africa. Thank you.
Should we take one more question if there is?
Thank you very much. Edward Mungai from Strathmore Business School. We have a program on training healthcare managers, so I shared some of the comments with the panel. Two questions. First, if you could share with us innovations on preventative healthcare, because I think we hear more of the curative ones, except of course for the X-ray one that we have had from PIC. Then the second one is on training for healthcare, because the discussion is still out there. Do you get a good doctor and train them to be a manager? Or do you get a good manager and train them to manage a healthcare institution? And how would make this work? Thank you.
Thanks very much. Two quite related comments. I think one about rural and primary care, and the other about preventive health. And those things are clearly, 90% of primary healthcare, 90% of conditions can be treated in primary healthcare, and obviously a lot more preventable. And then we'll come back to the management question. I'll open it up to the panel if you have thoughts on those.
Yeah, I can start. I think the issue of task sharing and task shifting, you mentioned it, but even though people nurses don't want to start doing duties that traditionally are supposed to be done by doctors, but through technology, they do have that enablement. We've got within Philips what we call a backpack, where we give to community healthcare workers who are trained to go and make diagnosis of diseases like hypertension, etc., in the communities. So to pick up diseases earlier or even preventative. We've got oncology screening programs so that we can start driving, not only through a product, but through a holistic solution. Because again, within healthcare, you can't just say, this product is certainly going to revolutionize healthcare, but it's how you package that within a solution and within different people so for you to improve healthcare. So in terms of preventative, we've got many products around. In fact, our value chain starts from prevention within Philips to say, how do you prevent? And you mentioned all the quadruple burden of disease. Most of the chronic diseases, you actually need to detect early or you need to prevent. Now, there is a catch around prevention, because prevention, it has to do with behavior and behavioral change. So you can innovate as much as you can in terms of bringing out a gadget, but if you can't innovate around behavior, it becomes another story. So this holistic thinking that says, if a person is going to be in this area at this particular time, what else can I bring so that they can change their behavior, so that they can eat better, they can eat well? Can you see now it starts going beyond the hardcore medical sector to bring in communities, to bring in leaderships in the community for you to change that behavior. And this is actually what we're trying to scale up within Africa. On your last points, I think the jury is still out there. Do you train a doctor to become a manager, or you train a manager to become a good doctor? I think there is a middle ground somewhere where you can get a doctor who is astute, who knows that medicine, and I know that very well, that medicine is not just about the stethoscope and making this patient well, because where they are coming from, it affects you. And also medicine is not about just my department only, it's about the holistic delivery of healthcare from a health post, primary healthcare, secondary, etc. So we do have individuals who could be cut out for this middle ground, and I don't think it's a done deal that this one is better than the other. I think there is middle ground. In an environment where we've got shortage of doctors, it may be an indictment to take this good clinician and suddenly put them in an office, they don't know what to do. So you need to balance between those.
Before I come to Giovanni and Kit, I just wanted to add in the word nurses here.
Yeah.
Because actually, in my experience, having worked in public healthcare, the nurses are a hell of a lot better managers than the doctors are. Because they get a lot of training of it on the job as well. And we've seen ministers of health, and even heads of African unions who started in nursing. So I would encourage that as part of the debate as well. Kit, Giovanni, I think any examples or comments you'd like to make specifically on, I guess, supporting community healthcare workers, primary healthcare, rural-based healthcare, or preventive healthcare?
Kit, maybe?
Well, I think you made the point very well, and in fact, Justice made the point in the question which he asked, and that is, if you really want to understand what the problem is that you're trying to solve, what you need to do is go out there into whether it be a rural clinic or even further, and really see the problem firsthand. And I think, and I speak now as an engineer, the mistake that we as engineers make is we've got this great solution, and then we go around looking for problems that we can apply it to. And I think the beauty of the model which Justice described there is, and what is working very well for this group from Northwestern University, is that the students who are being trained as engineers, who are getting that technical background, are getting the more empathetic insights as well, to try and understand what are those difficult things, those day-to-day problems that nurses and other healthcare workers are dealing with. And I think that's part of the secret of how we educate our young people. And I think there are real opportunities, not just when medical doctors go and do MBAs, but I think there are real opportunities in the kind of programs which Francois is running at the moment for business schools to go out into the community and really make a difference, and in this case, in healthcare.
Could I also go for it?
Add one or two things.
Oh.
Just in that primary care guideline, it had many challenges, way bigger than I expected. But one of the investors, and I think it was very astute, said it was one of our biggest projects. She said that we should spend more than half of the budget on the needs generation. But the really big problem is that process is invisible. So you come to your next project meeting and they say, we want to see something. We want to see a prototype. You say, no, we're spending time understanding the community. They said, no, actually, we don't want to see, we actually want to see a product. Okay. So there's a very strong drive towards, people are they lock in on the visible product. And so, I mean, I must confess, I wasn't able to stop that process of that shrinking budget. And then basically we ended up with probably 5 or 10% on the user. And it basically eventually asked to be taken off the project because I couldn't stand the fact that we were doing it that way. But that process of understanding the user, I think, is just so important. It's not to be underestimated. And things like design thinking help to give it a little bit of the words and the name of what are you doing. Why are you spending all this money on this, sinking it into this, where there's no obvious return for a while, but then eventually. The mobile clinics was another good example where there was a lot of time spent with the nurses, driving around with them and saying, what are your challenges? Is it the fact that the clinic is so hot because of the way the sun comes in, the windows, or the fact that you've got nowhere to store the files? Or what is the real problem? Not just and then mobile clinics are a great platform also for prevention and for rural. So, yeah, I think you just have to be very flexible.
Those are the big steps that we do need to overcome, is kind of finding ways to support primary healthcare workers and rural healthcare workers. I think if you look at a couple of examples in Africa, in the Gambia, there's a great motorbike program. So instead of mobiles in vans, in kind of especially with off-road and dirt roads, using motorbikes to actually provide care closer to people has been a very successful. I think they now supply something like 40% of all the transport vehicles for the Ministry of Health.
See, there's a bicycle ambulance that's been invented in Africa even.
There's a bicycle ambulance in Africa.
How difficult it must be.
And one of our students has developed a home-based chronic care delivery of medicines on bicycles in the peri-urban townships of South Africa around Cape Town. Was one of our entrepreneurial development graduates who was trying to deliver medicines for his grandmother and realized there's a big business in actually helping in reducing the waiting times of people and the opportunity costs of going to hospital, and he ended up delivering and created a small business delivering medicines to people. We're running out of time, or we basically are out of time. So unless there is one more burning question, then we can...
I'm Soren from University of Southern Denmark. I'm pleased to be here. I think this is a very interesting discussion, and this is more of a comment than a question, actually, because some of the things I've been hearing, also from Dr. Catherine, and in a very nice way, is that I think we have in business schools in general, not just in Africa, also where I come from, we have a particular problem is that we are generally a bit biased towards things that we can control, that is corporate managerial processes. So that's where we can sort of be on home ground. But the comment from Justice reminds me that one of my old passions is to shake business schools up a little bit. Polemically speaking, we can maybe say that they are not very interested in markets. Markets tend to get reduced to a demand curve and maybe a price mechanism and a few other things. But markets, as a trained sociologist, I think that markets are also beyond the price mechanism and the demand curve. They're also social systems. And unlike price mechanisms, social systems, they have a tendency to clog up. And having worked in the agribusiness research sector in Africa, I find the same problem here again. It's not so much that there are no solutions. People are coming up with really innovative, creative solutions all the time. The big problem is the dissemination, is getting it out there, is distribution. And it's so more focus, I think, for all of us, I think it's healthy to think of focus on markets as systems, on distributions and channeling, and not least on the consumers, the customers, the patients, the people out there who have the actual problems. So I'm a consumer behavior researcher, so of course that's also speaking my home turf. But I think it's a very obvious thing that we tend as business managers to overlook a little bit, because it's not so easy to handle as the internal processes, the corporate processes that we run. Thank you. Just my 2 cents.
Thank you, Soren. And I think actually the things you spoke about actually speaks to opportunities for business schools to be involved in exactly taking some of these things to market, whether it be the organizational elements, the distribution, supply, financing, all of those aspects of it. So thanks for your comments. And Edward, I'm sorry we didn't fully address the doctor versus manager debate. I'm not sure if we would get to any resolution in the minute, but I think it's been tabled. Thank you, special thank you, maybe just a round of applause for the panelists.